Our next speaker is Dr. Paul Yonga from Kenya. Dr. Yonga currently serves as a consultant in international health for EASO and EU member states, and is also an infectious disease consultant at the CA MedLink's Tropical and Travel Medicine Infection Diseases Clinic in Nairobi and the Fountain Healthcare Hospital in Eldoret, Kenya. He is experienced with HIV preventive services, as well as infectious disease and tropical travel medicine, along with research in the regions of Eastern and Central Africa. Dr. Yonga will present on COVID-19 lessons learned in Kenya. Dr. Yonga.
Well, thank you very much, Kevin, for that kind introduction, and thank you to the organizers for inviting me to present on some of the lessons that Kenya has learned through this tumultuous 1 year that we've gone through the pandemic. So in my talk, I'll list a bit of the background to where we found ourselves encountering COVID-19 in Kenya and how Kenya has responded to this pandemic to this date. And then I'll mention a couple of challenges that we still face as we move forward in addressing this pandemic, and a few thoughts moving forward in the conclusion. So when you look at how Kenya encountered COVID-19, this happened in the 12th of March, 2020. Initially, this was the first case that was detected at the National Public Health Laboratory in Nairobi, which is a lab that we use for our influenza surveillance. Previously, we didn't have any diagnostic capacity, and so a lot of our samples were being sent to the National Institute for Communicable Disease in Johannesburg, South Africa. But this was the first case that was actually detected within our local setting, but also had to be confirmed at the NICD in South Africa. And this case was really about, I think it was a 25-year-old female who had a very extensive travel history, had come 2 weeks prior to the presentation, had come from Los Angeles, traveled to New York, took a flight from JF Kennedy in New York to London Heathrow, then landed in Nairobi, and 10 days later presented to hospital with symptoms. And so after that, really what happened is that moving forward up to just about 2 weeks ago, we've now had just slightly over 170,000 cases. Of course, the majority being community transmission. But of course, during the first period, first two to 2.5 months, a lot of the cases were being reported were more imported cases. And so in Kenya right now, we're just sloping down towards our third wave. We're stabilizing on our third wave, but we are also anticipating a fourth wave in the next couple of weeks. About 2 weeks after the first case was detected, that we even recorded our first mortality from COVID-19. And because of this, we could actually find that from that first case that was reported on the 26th of March, up to the 2nd of June, we've lost just up to about 3,200 people to COVID-19. Also, the mortality curve demonstrating itself in 3 waves. And so based on this, a couple of colleagues, myself included, tried to look at the epidemiological and clinical characteristics of patients presenting to hospitals. At that time, we only had 4 hospitals treating COVID-19 patients, because at the time it was all the government had taken full control of managing patients. And at that time, the private sector really was not heavily involved because the cases were quite few. But right now, the private sector actually plays a key role in management of COVID-19 patients in Kenya. And what was actually found was that over the 5-month period between March and August of last year, having studied just slightly over 780 patients, with a median age of 43 years, slightly less than the 62-year age median that we found in Italy. 43% had pre-existing comorbidities, of course, with 17% having cardiovascular disease, and just about 30% presenting with risk factors for cardiovascular disease, that is being diabetes, HIV, as well as chronic kidney disease, and just about 11% of these patients requiring intensive care unit admission. And so when you look at the box and whisker plot, you'll find that really the biggest risk factors for mortality were patients, really the elderly patients, patients above 60 years of age, patients who had history of any chronic conditions, and particularly patients with chronic conditions that had not been well controlled. We tend to have a very significant double burden of both infectious disease and non-communicable disease. And some of the patients who have non-communicable disease tend to present to hospital when those conditions have not been optimized in terms of therapy. And so those are some of the patients, unfortunately, we ended up losing in hospital. And then as well, the male gender. Of course, We don't still know why this is the case, but of course, due to the outgoing nature, especially in Kenya, this could be one of the reasons why the burden was significantly felt among the male gender. So, based on that brief background, how has Kenya responded to this pandemic? And so what initially happened was that from the first index case, 2 additional cases were reported 3 days later. And this necessitated the President of the Republic of Kenya to actually address the nation. What could be some of the mitigating or some of the preventive measures that the government would take to keep the cases as low as possible. And so one of the things that was initially done was to constitute a National Emergency Response Committee, which was under the leadership of the Cabinet Secretary, Ministry of Health, with support from the Cabinet Secretaries in the Transport Ministry, Education Ministry, Water and Foreign Affairs, as well as Interior and National Security. And this National Emergency Response Committee was being supported by technical working groups. Personally, I sat in one of the technical working groups that was addressing issues of setting up isolation facilities as well as therapeutics for COVID-19 patients. And also during that time, there was suspension of travel for all inbound travelers from countries that were reporting cases. And at that time, the 2 biggest countries that were reporting very high numbers of cases were China and Italy. So for those 2 specific countries, actually flights were completely blocked from those 2 countries from accessing the Kenyan airspace. And also at that time, Kenyan schools were closed. All government employees and civil servants who are 55 years and above were mandated to work from home. Kenya is a country that has embraced cashless transactions, especially with widespread use of mobile money transfers. So encouraging use of cashless transactions was not very difficult. However, minimization of crowding up to date still proves to be a significant challenge due to the human nature of humans being social. And so the biggest restriction that was implemented by the Kenyan government was in terms of lockdown. And the first lockdown, and they were not really generalized countrywide lockdowns. They tended to be very localized because when the pandemic started, 5 counties were reporting very high cases of COVID-19. And this was Nairobi, Mombasa, Kwale, Kilifi, and Mandera. Mombasa, Kwale, and Kilifi, for those of our audience who are not very familiar with the Kenyan terrain, Mombasa, Kwale, and Kilifi are really big counties along the Kenyan coast. Then, of course, Nairobi being the capital city where a lot of the economic activity within Kenya is conducted. And then Mandera is really on the border between Kenya and Somalia. So this is where a lot of the cases were being reported. And so because of this, on the 6th of April, lockdowns were imposed on these 2. And then the second lockdown, when the first lockdown was still ongoing, the second lockdown now was localized within the counties itself. So within Nairobi, there were also small lockdowns implemented within. And so one of the biggest ones was Isli, which is a very big business transaction center. It was also contributing a third of the cases that were being reported in Nairobi. So that had to be locked down, as well as Old Town in Mombasa, which is next to the Fort Jesus ruins, also had to be locked down. And it was locked down for 2 weeks, but kept on being extended. However, these lockdowns were fully relaxed on the 7th of July. That was about 2 months later. And 1 month from that, there was a complete easing of movement, whereby even international flights were being allowed to enter. When you notice that the epic curve, you'll find that the complete easing of movements was actually being done when you were at the plateau of the first wave of the pandemic. But at that time, the cases were dropping down. Then when it reached October of last year, then you are now seeing another spike in cases, which actually now led to significant morbidity and mortality, especially among healthcare workers. And so that wave actually extended for just about 3 months before it subsided. And so during that period, apart from the curfews that were in place, there were no lockdowns that were imposed. So it was just until last month, 2 months ago, there was a significant spike in cases, and that is now when we were reporting a lot of cases from the South African variant. And so because of this, another lockdown was again imposed. This time, Nairobi was again included, but in addition, there were 4 other counties which are neighboring Nairobi. So those ones were also included, but all this was just a month ago. And so because of this, there was a lot of misinformation floating around the country. And so because of this, Kenya had to come up with some very good messaging. And this one, you can find it is actually in Kiswahili, but with a bit of what we call slang, to make sure that it also appeals to the youth, but as well as to the children that are growing up, to make sure that they're in line with what was actually happening and to be well informed about all this. And just like the Singapore story, Kenya actually implemented mandatory mask wearing quite early in the pandemic. Actually, it was just about 2 weeks after the first case was reported. And this was when the WHO had reported that there was still a bit of dilemma and a lot of questioning on the utility of masking if you are asymptomatic. But by that time, I think Kenya just took a bold decision to implement mandatory mask wearing. It was not a very popular decision among Kenyans and also amongst our neighbors, that is Tanzania and Uganda. But over time, they had to accept what Kenya was implementing. And of course, now a year later, one of the other responses has been the vaccine rollout. Of course, it has been very, very slow. We've still not picked up as much as we wanted to, especially due to the shortages that we're experiencing globally. And it was because of this that there had to be development of strategies to drive this vaccination. And one of the things, this strategy of implementing the vaccination was that for any vaccine that had been approved by any regulatory body outside of Kenya, be it the FDA, the MHRA in the UK, the EMA in Europe, so long as it has been approved by those bodies, the Pharmacy and Poisons Board in Kenya would approve those vaccines within a week, as opposed to the 3 months that it takes to review and approve any therapeutic agents in the country. Of course, there's a lot of planning and coordination being done at the central government with a lot of collaboration from the devolved units. The funding has been a mix from COVAX. So COVAX through Gavi is funding 20% of the vaccines that we are currently accessing in Kenya. And in Kenya, we are mostly using the AstraZeneca vaccine, but from September, we should be using also the Johnson & Johnson vaccine. Then 10% is footed by the Kenyan government. And then, of course, now the major issue was now how to phase the vaccination strategy and identifying the target populations. And so this was to be done in 3 phases, and this was only contingent on vaccine availability and would be phased out over a 2-year period. So when you look at the vaccination phase, it is quite dynamic because you can see in March 2021, our phase 1 included healthcare workers and the frontline workers, that is the teachers, security forces, and the immigration officials. But in April, what actually happened is that there was significantly high mortality, especially among the elderly, that is 60 years and above. And that's a population that had been earmarked for phase 2 of the vaccination strategy. But based on that very high mortality and the very high admission rates among that group of people, then the ministry took the bold decision of moving them up to phase 1 so that they can also be protected as much as possible based on the availability of the vaccine. However, the vaccination phase still kept being very dynamic because right now you find that we are just tending towards the Olympics in Tokyo. And so because of that, the sporting industry, which had been earmarked for phase 3, were pushed up to phase 1 so that they could also be covered. And right now in Kenya, there's also the World Rally Championship, whereby also these people needed to be covered in the vaccination. So Kenya has faced quite a number of challenges with regards to responding to this pandemic. Some of them have been historical, but have literally just been blown wide open by the emergence of COVID-19, to which some people say it's a blessing in disguise because now it had to force Kenya to start improving on some of the issues that they have been bedeviled with. Of course, the first and the biggest problem was stigmatization. And a lot of my colleagues, some of my senior infectious disease colleagues, actually equated this to what was faced during the HIV pandemic when Kenya reported its first case in 1984. These were the scenes that could be found, whereby there was a lot of militarization of the pandemic by controls. And of course, now this is a period where people are being beaten up at night, being forced into their homes, some of them unfortunately losing their lives. The other thing that also happened is that in Kenya, we had a curfew. The curfew is still in place, which starts from about 10 p.m. But when the pandemic started, the curfew used to start at 8 p.m. What used to happen is that when people will be found outside after 8 p.m., they will be quarantined the same way someone who had been in contact with a COVID-19 case would have been quarantined. This brought a lot of stigmatization, and people are not very impressed about it. So a month later, this directive was reversed. The other challenge we've really faced, and I've really mentioned it early, is the limited vaccine availability. You can see the vaccine coverage globally. Our colleagues in the US and Canada are doing quite well, as well as mainland China. You can see the entire African continent. We have a very big problem and a very significant challenge. And this can be equated really the percentage of people who've received their first dose. You can see like in Malta, where I do a bit of work for years, so just over 60% have received their first dose. And that cuts across the first graph, as you can see, just over 60% have received their first dose. But now when you look at Africa, I mean, most of the low and middle income countries, Kenya being on the far right second row, we'll find that just slightly less than 2% have actually received their first dose. So this is really a significant challenge we face in most low and middle income countries. And this is what made our Kenyan health minister to actually say that Africa must stop believing that the entire globe will run to its rescue with regard to this. So we've really had to think innovatively and see how Kenya can remain protected against the pandemic. The other issue that we've really faced is the problem of limited testing capacity. You will find these are samples tested over a weekly period. So you'll find that just in last year, and these are numbers that are not any different from our current scenario, we've been testing averagely just over 28,000 samples per week. This is a marked far cry from the samples that are being tested by our neighbors in the south, that is South Africa, who are testing 10 times that in one single day. And we are testing 10 times less that in a week. So you can actually find that a lot of cases are being missed. And that is also attributable to the expensive cost that because patients have to pay for these tests themselves, and most of them cannot afford. It costs just about $100 for a PCR test to be run on a patient. The other problem that we've faced during this pandemic are the poor working conditions and industrial unrest. This has been a historical problem, but this also skyrocketed during the pandemic, whereby you find doctors downing their tools over lack of PPE, which was a very significant problem during the start of the pandemic. Doctors were staying even close to 4 months without pay in very risky conditions. And so this became a very significant challenge during this pandemic. And unfortunately, it ended up in very sad scenarios where we lost one of our younger colleagues due to COVID-19. And this is someone who had not been paid for the last 3 months at 28 years old, someone who's just coming up to be a promising doctor in the country. So these are some of the challenges really that have afflicted the COVID-19 response in the country. And then the other issue has been increased political activity, which leads to including very limited mask wearing, as you can see there, because in Kenya, we are heading into a political season. 2022 will be our general elections. So already campaigns are on very top gear with little regard for social distancing or some of the other preventive measures. Of course, now fueling some of these spikes as we see them. And of course, we cannot rule out the variants. Just a month ago, we reported 5 cases of the Indian COVID-19 variant in Kisumu, that is on the western side of Kenya, next to Lake Victoria. And this is one region that is also heavily burdened by HIV. Right now, as we speak, they confirmed 5 cases just a month ago. Right now, that region alone accounts for a third of the cases that are being reported in Kenya. Now, I think just about 800 cases alone coming from Kisumu, and just about 90% are being fueled by the Delta variant from India, then another 8% by the South African variant, and then the other split between the UK variant and the wild type virus. Of course, corruption has been part of our system for quite some time, but of course now in Kenya, it also was blown up quite significantly, whereby a lot of stealing happened really during procurement of COVID-19 equipment, where we lost close to $72 million, whereby that money cannot be accounted for from the control of budget and the audit of government. So these are some of the challenges outside of the normal floating of the virus. There are also systemic problems that existed prior to the pandemic coming in. There was also issues of importing COVID-19 vaccines by the private sector. And here, the vaccine that was isolated was the Sputnik V, which has not been approved by the Kenyan authorities and had also not been approved by the WHO and the emergency listing, but somehow found its way into Kenya, and some people actually were vaccinated using it. So there are quite a number of challenges amongst these. And so really to conclude, Kenya still has a very long way to go in controlling the pandemic, of course, based on the myriad of challenges that we mentioned. And just as Kevin mentioned in his introductory remarks regarding the strategies, Kenya currently is employing the suppression strategy, whereby you try to keep your cases as low as possible, either through restrictions, mask wearing, but of course now with the myriad of challenges based on very expensive therapeutics that we are using that patients cannot afford, testing is very expensive and the vaccine availability is quite low. So those pose a significant challenge to the suppression strategy. And because of this, that we really need global collaboration to be able to increase access to therapies and vaccine research and access. And with that, thank you very much.